Welcome back, guys. This time we shall be talking about heart sounds, part 2. I'll be focusing on second heart sound first, which is characterized by aortic and pulmonic valve closure. The time lag between the aortic and pulmonic valve closure both do not close on the same time. The gap between the two is approximately 30 milliseconds. This is technically called as physiological splitting of the second heart sound. The physiological splitting of second heart sound is best heard in the phase of inspiration. So whenever you see a physician asking the patient to hold his breath, and he's putting his stethoscopes at the ears point, then he's trying to listen for the splitting of the S2. In the paper, they have asked regarding the position of the ears point. The ears point would be the left side of the chest, the third intercostal space, parasternal line. I've just used a short form here. PSL would mean parasternal line. So I repeat my statement. Every time you see a physician putting his stethoscope on the chest of the patient at the ears point and asking the patient to take a deep breath and hold it there, he's trying to check for the splitting of the second heart sound. And this physiological splitting of the second heart sound has a time lag of 30 milliseconds. Now, if this gap will be less than 30 milliseconds, we call it narrow split. And if the gap is more than 30 milliseconds, we call it a wide split second heart sound. So I'll be giving some clinical conditions to you. I will not start by saying whether it is narrow or wide. I'll just describe the condition and you will be able to evaluate whether it is a narrow or a wide split second heart sound. In the first sketch that I'm making before you, I'm showing valvular aortic stenosis. So if you look at this particular sketch, you see the surface area of the aortic valve is approximately 2.5 square centimeter. And I have made it really small. So if this opening is smaller, the left ventricle will eject this blood into the aorta of the patient. There's obviously going to be a turbulence, there's obviously going to be a murmur in the patient. But at the moment, we are just focusing on the fact that in all patients with valvular aortic stenosis, you can see that our heart is genetically programmed to kick out 80 ml of blood. I want you to compare this patient with yourself, because you can see the opening is smaller. The exit of 80 ml of blood, if you just imagine this person sitting on a chair next to you, the basic point is because the exit of 80 ml of blood from this smaller opening will take relatively extra time. Therefore, the aortic valve of the patient cannot close on time and the aortic valve will show relatively a delayed closure. In case you missed it, I'll say that again. I want you to compare this patient by yourself. The opening is smaller. If the blood has to go out of a smaller opening, it will take extra time, and extra time would translate into the aortic valve will close relatively later. If the aortic valve of the patient will close later, I'm going to put these two lines, the A2 and the P2, on a two-dimensional scale, and then I'm going to say that because aortic valve will close later, I'm going to shift it slightly to right to say that the gap will become relatively lesser between the two lines since they're coming closer to each other. So in patients who are having valvular aortic stenosis, the delayed closure will result in development of a narrow split second heart sound. The best management for a calcified stenosed aortic valve is aortic valve replacement. But let me say, poor patient in India did not get aortic valve replacement surgery done. Then this is a progressive condition and this gap will become even more narrowed. And if this gap will become narrowed, then I think you would agree that exit will take still more extra time. In these circumstances, what's going to happen in the patient is that the aortic valve will close still more later and the gap will become progressively reduced. And there can be a possibility one day that the aortic and pulmonic valves might start closing at the same time. The aortic valve is closing later, still more later is superimposing, and there's a possibility that both are closing at the same time. Then we're going to call it a single S2. And there is also possibility in these patients that the aortic valve closure might occur after the pulmonic valve closure. You can see the overshooting happening here. It's coming closer, superimposing, overshooting. The overshooting is called as P2A2. This would be referred to as a reverse splitting of the second heart sound of the patient. So the sequence that I want you to remember is that in all patients of valvular aortic stenosis, pending a treatment, the patient will be having first a narrow split second heart sound, does not take treatment, gets converted into single and then gets converted into a reverse split second heart sound. Max to max in some MCQs, instead of writing the word reverse split, he might write the word paradoxical splitting of the second heart sound of the patient. So this is the sequence that you should be aware of. And in the exam, you see, you won't have time to, draw these lines and understand it on a two-dimensional scale. They don't even give you a paper pencil. So it's just an orientation that I want you to have right now, because in the exam, you operate on a reflex. So the message is that exit will take a relatively extra time. Aortic valve closes later. That is why you are having a delayed A2 and a subsequent series of events that I have explained to you. The best management for these patients is AVR, that is a aortic valve replacement. Well, just let's look at why do you have aortic stenosis anyway presenting to you. In the exam, if they give you valvular aortic stenosis for an infantile presentation, then the most common cause of valvular aortic stenosis in infantile age group is bicuspid aortic valve. However, if he begins by saying a child, then it is rheumatic heart disease, and in rheumatic heart disease, all of you are aware that mitral valve is the most common one to be involved, but the second most common valve involved is the aortic valve. So child with rheumatic heart disease would be having aortic stenosis. Aortic stenosis is not seen in young people, so it's not going to be seen in you at, let me say, 25 years of age, or me at, let me say, 42 years of age. In an adult patient, if they say, you are unlikely to have this aortic stenosis presenting at your or my age group, most of the time it's going to present in geriatric age group, that is after 65 years of age. And the reason for this geriatric presentation is senile calcification of the valve. So one, you have to understand that this disease has a bimodal age of distribution. It is either seen in pediatric age group or is seen in geriatric age group. And why do these patients of valvular aortic stenosis come to us? That is because of SAD. This is a triad which has been asked a couple of times. S would stand for syncope on exertion. This syncope on exertion is explained by low cardiac output in these patients. Since you can see there's a valvular narrowing, so the cardiac output of the patient is very limited. So if he's trying to climb stairs, like let me say with a backpack on his back or any kind of load or a rucksack on his back, whatever, then low cardiac output can cause ischemia of the brain and syncope. Patient can pass out. A would stand for angina in these patients. The reason for angina in these patients is, and I'll just swap the slide for it, that in a lot of these patients, because there is an obstruction in the heart, there would be a compensatory LVH, a left ventricular hypertrophy. And you know that whenever there's a left ventricular hypertrophy in a patient, the oxygen demand of the heart will increase. This mismatch between demand and supply, because demand is more, you see more muscle, more demand, supply is going to be normal. I'm not saying supply is lesser, mind my words there. I never said supply is lesser. I said demand is more, supply is normal. So there's a mismatch between more demand and a normal supply, that is subendocardial ischemia, which in English we call as angina. This angina is because of mismatch between the demand, which is increased, and the supply, which is normal. The third manifestation in these patients is going to be developmental difficulty in breathing, which is anyway a presentation of any cardiac case, and here the increased left ventricular filling pressures will explain the pulmonary edema component. The dyspnea here is diastolic malfunction. SAD is a triad which has been asked in the paper for valvular aortic stenosis. Now let us see what are the examination findings of these patients. Apart from the heart sound aspect that I mentioned before you, we will also evaluate the pulse in this patient. The character of pulse is best evaluated in the carotid artery. This is the tracing of the pulse that I'm going to show before you for all of us. The pulse tends to peak in the middle of systole. Then the pressure tends to ease off and you have a dicrotic notch, and then you have is a fall. In fact, they have simply represented this dicrotic notch in an image-based question, and they have simply asked that dicrotic notch is present right after the answer is second heart sound, as you can see. The peak of the pressure is generated in the middle of systole. This peak of the pressure that is generated in the middle of the systole is a feature in you and me. In valvular aortic stenosis, because there's an outlet obstruction, a fixed valvular obstruction, it takes time for the pressure to rise and the peak of the pulse is delayed. And you can also see that in this particular patient, I have shown a pulse tracing with a relatively smaller dicrotic notch. One of the special features of this pulse is that this is a slow rising pulse. Apart from the slow rise in the pulse, you can also notice that the amplitude of this pulse is also relatively lesser. You can also see that in this pulse tracing, the dicrotic notch of the patient is very, very small, to the level that in some cases, the dicrotic notch of the patient might practically be absent. So the basic message is that whenever you gonna read about this pulse slow rise with a decreased amplitude and a dicrotic notch which is almost absent to practically being very small or being absent, then the terms that you have to remember for the slow rising pulse is known as pulsus tardus. I'm just writing the Latin terminology corresponding to the English words. The word is pulsus tardus. At parvus, the word is to highlight the fact that there is a decreased amplitude. And for the absent dicrotic notch, the word called is anacrotic pulse. In fact, this has been a national board question that in which pulse the dicrotic notch will disappear. Then the answer would be valvular aortic stenosis, where the pulse is referred to as an anacrotic pulse. This is the first finding that I want you to remember for patients of valvular aortic stenosis, pulsus tardus at parvus / anacrotic pulse. Then these patients will also be having a double apical impulse. The double apical impulse of these patients is explained by the fact that in these patients, the heart is relatively bigger, so the apex beat in these patients can be evaluated in the fifth intercostal space as well as in the sixth intercostal space. So fifth and sixth intercostal space is where you are able to evaluate the apical impulse of the patient. These patients will also be having a heaving apex beat. The word heaving apex beat implies the fact that the impulse will be so forceful that it will lift up your finger. Then in these patients, when you listen to the second heart sound, S2, in the second heart sound of these patients, you will be able to notice that the patient is having a narrow split second heart sound. As I explained to you, this is because the opening is smaller, blood will take more time to go out of the heart, so aortic valve will close later. Though in some MCQs, he might write the word single S2 or he might write the word paradoxical S2, paradoxical split second heart sound, to imply the severity of the disease as it increases. In these patients, not only would you be having a left ventricular hypertrophy, but a left atrial hypertrophy also. I'll just represent that on the previous slide. As you can see, these patients will also be having a compensatory left atrial hypertrophy. The reason for left atrial hypertrophy is simply by the fact that the responsibility of sending blood out of the heart is not only the function of the left ventricle but also the left atria. So because the left atria of this patient will be generating relatively more force, therefore in these patients the left atrial hypertrophy will generate atrial kick. Why I'm writing atrial kick is the atria of the patient is generating more force than yours and mine. So left atrial hypertrophy is responsible for generation of fourth heart sound of this patient. And since you could see the turbulence while the blood was going out of the heart, when you will be auscultating this patient, you will be able to hear a murmur. The speciality of this murmur will be that this murmur will be having an increase and decrease of the spike of the murmur, or I can say the intensity of the murmur will not be constant. The intensity will first rise and then will decrease. This is discussed in the murmur section also and is called as ejection systolic murmur. Ejection systolic murmur is also called as crescendo, decrescendo murmur, as is written in Davidson, the British book. But most books do not use the word crescendo, decrescendo, but they tend to use the word ejection systolic murmur, where the intensity will first rise and then the intensity will tend to go down. So the sequence to be remembered by you is simply the fact that these patients will be having a narrow split second heart sound, an anacrotic pulse, a fourth heart sound, and an ejection systolic murmur. The best test to confirm the diagnosis of this condition will be echocardiography. Once you have identified this condition on a transthoracic echo, since most of the patients are older patients, older than 65 years of age, it is also a good idea to simultaneously scan them for presence of atherosclerotic changes in the coronary arteries. So in these patients, we also not only do a transthoracic echo, but we might even be requiring coronary angiography in these patients because I want to evaluate that the angina component is simply because of presence of LVH, or is it due to coexistent atherosclerosis or triple vessel disease. So I will also be doing a coronary angiography in the patient, and in most of the patients we are able to identify coexistent atherosclerotic lesions. Considering the age of the patient, a lot of these patients might be having a coexistent triple vessel disease for which they might be requiring a coronary artery bypass grafting. So if they ask you what is the treatment for this chap, the treatment of choice for symptomatic patient of severe aortic stenosis, mind my words there, symptomatic patient, not asymptomatic. If he tries to be smart and introduces the word asymptomatic patient, then in those circumstances for the asymptomatic patient, we do not operate. You see, the point is, asymptomatic people, it's a dicey situation, and most of the time we would like the patient to be symptomatic and then operate. But for a symptomatic severe aortic stenosis, if he says what is the best treatment, then it is AVR, that is aortic valve replacement, which is nowadays done percutaneously, and along with aortic valve replacement, if required, coronary artery bypass grafting would be also done in these patients. Do remember the fact that if in the MCQ he mentions a pediatric aortic stenosis, then there is no need of answering a AVR or CABG. Obviously, for pediatric aortic stenosis, the treatment should be given as balloon valvotomy. The main message is that you should be able to identify the heart sound in these patients with respect to the information that I have mentioned clinically plus the heart sound aspect. A lot of time in MCQs of valvular aortic stenosis, he might actually say a word that I would like to add now, and that is based on the turbulence. You can see that in these patients, there is a lot of turbulence of blood going out of the heart of the patient, which is responsible for a murmur. So another finding that I can add to the current slide, so that you can remember the features of these patients, and would be an additional examination finding of this person would be that after the murmur, I can add the word carotid thrill. Whenever you read this word carotid thrill, it is so accurate that it straight away tells you that the question is on valvular aortic stenosis. So most examiners will avoid writing this in the question in the theory part. At the same time, I also want you to pay attention to the fact that in some MCQs, he might write the word dancing carotid. If the examiner is going to use the word dancing carotid, then dancing carotids is a feature that is encountered in patients of valvular aortic regurgitation, whereas carotid thrill is a feature of valvular aortic stenosis. So though I said examiners might avoid writing this terminology, they might deliberately introduce the wrong term dancing carotids, which is not a feature of this particular condition. In some questions, however, they might actually try to trouble you by mentioning what do you mean by the word severe aortic stenosis. Then severe aortic stenosis is characterized by narrowing of the aortic valve orifice. Transthoracic echo, you can actually see the size of the aortic valve orifice. Because the opening is smaller, the ejection velocity will also increase. So definition of severe aortic stenosis, when do we say patient is having severe aortic stenosis? Then severe AS would be less than 1 square centimeter of the valve surface area. Or in some questions, he might not write the word orifice of the valve, but might actually mention regarding transvalvular gradient. What I mean by transvalvular gradient is the pressure difference between the left ventricle and the aorta of the patient. If the transvalvular gradient is given to be more than 40 millimeters of mercury, we take it to be severe aortic stenosis. And in these patients, because the opening is smaller, the ejection velocity of the blood going out of the heart is also increased. If the ejection velocity is more than 4 meters per second, we are going to call it a severe variety of aortic stenosis. Normal ejection velocity for you and me is going to be approximately 1 meter per second, but if the ejection velocity is to the tune of 4 meter per second, we call it severe aortic stenosis. A new term that has been introduced recently in MCQs has been super severe aortic stenosis. Now when I say super severe, then in those circumstances, I want you to remember that the transvalvular gradient, that is LV minus aorta pressure, should be more than 55 millimeters of mercury. Or for that matter of fact, for transvalvular gradient, he might write the word ejection velocity These are like kind of parameters which tell you that straight away that intervention is required for the patient, because you see with these kind of values, patient is symptomatic and obviously threat to life with respect to physical activity causing angina and then possibly MI also. So super severe is more than 55, 5.5 straightforward data. Severe variety is gonna be answered by you as 40 and 4 millimeter. 4 meter per second, 40 millimeter transvalular gradient and ejection velocity more than 4, and super severe is 55 and more than 5.5. So those are like the terms that you need to remember for the severity of the disease in the patient. And just revise this data once and you'll be able to crack questions with respect to valvular aortic stenosis, which is characterized by presence of a narrow split second heart sound followed by a single followed by a paradoxical split, which is the important information here. Now, once you get a hang of this, let's look at another perspective. This time again, I will not mention whether the person is having a narrow split or a wide split second heart sound. I'll simply draw the condition before you, and then we will evaluate whether there will be a narrow or a wide split second heart sound. So just be patient while I just make it before you. This can be taken as the representation of the aorta and the pulmonary artery. This is the pulmonary artery bifurcation. In the sketch, what I have done is that I have shown here is an anatomical abnormality, that is ductus arteriosus, which is patent. You see, ductus arteriosus normally closes after birth. In this particular case, however, I have shown patency of ductus arteriosus. You can see that the oxygenated blood present in the aorta will race obviously into the descending aorta, but some of this blood will be racing by the patent ductus arteriosus directly into the lungs of the patient. This is an example of a left to right sided shunt. You can see this is left ventricle, this is right ventricle. If they ask you that for a case of a patent ductus arteriosus, which ventricle will fail, then the ventricle that's going to fail in this particular case is not going to be the right one, because you can see very clearly blood is not going in the right ventricle. The blood is bypassing the right ventricle, straight away racing to the lungs of the patient. And all the blood that comes into the lungs is going to race to the left side and is going to cause overloading of the left side of the heart. Therefore, patent ductus arteriosus is a condition which is a left to right sided shunt, but it does not cause a right ventricular failure, it causes a left ventricular failure. When it comes to left ventricular failure, I just want you to focus on the word failure. Failure would mean that the heart is not having sufficient power, so exit of blood out of the heart will take relatively extra time. And because exit of blood out of the heart of the patient will take relatively extra time, the aortic valve of the patient will close relatively later. You can see the fact that because the aortic valve of the patient is not going to close on time and is going to close relatively later, I'm going to just show this on a two-dimensional scale before you, the aortic valve closure and the pulmonic valve closure. I've worked out before you that the aortic valve will close later, so the gap between the two will become relatively lesser. And therefore, in cases of patent ductus arteriosus, there would also be a presence of a narrow split second heart sound. What you've learned at the moment is that narrow split second heart sound can be seen in physical obstruction of the aortic valve and is also seen in left ventricular failure. The logic in both of them is identical. No, in valvular aortic stenosis, there is a fixed obstruction, whereas here the heart is simply not having sufficient power to generate the force necessary to remove the blood out of the heart, so the aortic valve closes later, and therefore you have a delayed A2 and a narrow split second heart sound developing in a patient. Before I describe other causes of left ventricular failure, which would again result in narrow split second heart sound, let's just quickly look at what is the presentation in patent ductus arteriosus. When it comes to preterm children, they become symptomatic right at birth. But when it comes to term children, the term children usually become symptomatic as early as 6 weeks of life. Now, what is gonna be the mother of a 6-week-old baby gonna tell you, or a preterm baby in a NICU? What are the findings? These kids, if they are put on breastfeeding problems will definitely be seeing that the mother will say that whenever I feed my child, he is not able to take the feed very properly, simply because there is an effort intolerance in the child. So the child will become very dyspneic. So for her, it's a feeding problem. But for you as a doctor, you have to understand what she means by feeding problem is that once she says, especially educated mother, she will say that, doctor, I notice a lot of sweating on the forehead of my baby when I'm feeding my child, because all of you know that heart failure is a sympathomimetic condition. And second, she is also saying that the intake of milk by the child is very, very less, simply because he becomes very breathless. Now, she doesn't understand the breathlessness of the child. She will just say that the child leaves the breast midway, is not able to take the feed for a sufficient duration. This will make the child very cranky, and she will say that this is a very irritable child, doctor. I have to put him to breast again and again. He takes it for a while, then leaves the breast because he's having a low cardiac output, so he's not able to sustain the effort required for breastfeeding. So when you listen to the history, first you might be thinking that it's a mother who's exaggerating the symptoms, or there's maybe some pediatric aspect with respect to attachment. But your clinical skill would tell you that this child is not having any attachment problem, which you study in pediatrics, but is rather gonna be a cardiovascular problem in lieu of the fact that there is a narrow split second heart sound. And second, there's gonna be a murmur in this condition, which is based on the fact that you can see that the blood is racing from high pressure to low pressure area. So there's gonna be a continuous murmur, also referred to as machinery murmur in this condition. The highlight of a continuous murmur is that it is heard in the phase of systole as well as in the phase of diastole, and the peak of the murmur is present at S2. This murmur that I've highlighted before you, which is present in both systole and diastole, is going to be the one which is referred by pediatrics people as machinery murmur, though in medicine we tend to call it as a continuous murmur. So the highlight is that narrow split second heart sound and machinery murmur will help you in identifying a patent ductus arteriosus. For these particular patients, the investigation of choice will be a transthoracic echocardiography. If he mentions what is the treatment for a preterm baby with a patent ductus arteriosus, then for a preterm child with a patent ductus arteriosus for prematurity, the answer will be given as indomethacin. This will inhibit prostaglandin E1 production, which is responsible for patency. But if he says term child, the answer would be given as surgical ligation for this particular condition. In the paper, he tried to be smart and he said 1 year-old child with patent ductus arteriosus. And he said, what is the treatment? The answer would again be given as surgical ligation, with only for prematurity, the answer should be given as indomethacin. The basic concept that you learned from this particular slide is that whenever there's a LVF, there's a narrow split second heart sound. I just used a pediatric condition to highlight left ventricular failure. Based on the explanation that I provided to you at the moment, I want you to remember that whenever they ask you regarding narrow split second heart sound, your thought process should be that either the patient is having a presence of outlet obstruction with respect to the left ventricle, or there's a failure of the left ventricle. Outlet obstruction to the left ventricle is fixed in the form of valvular aortic stenosis, or he might say the word subvalvular aortic stenosis. Subvalvular aortic stenosis is going to be hypertrophic obstructive cardiomyopathy. You can listen to the cardiomyopathy section for detailed discussion of HOCM, which is given there. And then is left ventricular failure. Now, left ventricular failure in the exam can be written as anterior wall myocardial infarction, or it could be written as patent ductus arteriosus, the pediatric relation that I said, or he might just say the word Coxsackie B myocarditis. Or he might write with respect to alcoholic the word wet beriberi. Thiamine deficiency contributing to heart failure in a patient. Or it's a woman from rural India who's having multiple children. She had like 3 pregnancies in last 1 year. She's severely anemic and she's gone into heart failure. The basic point is that any of these terms could be written by the examiner to describe LVF in a patient. And you should be able to identify that whenever it is LVF, it's a narrow split second heart sound. Now, we're going to talk about opposite of this, that is a wide split second heart sound in a patient. So now listen to the input for wide split second heart sound. The condition that I'm showing before you is a complication of myocardial infarction, mitral regurgitation. In this particular sketch, what I'm showing is when the left ventricle of the patient will contract, and so will the right ventricle, obviously 80 ml blood will race into aorta and 80 ml blood into pulmonary artery. But you can see a substantial amount of blood leaking into from LV to LA. Now let me say hypothetically that 10 ml blood is leaking. It could be 10, it could be 15, 20, whatever. The point is that our left ventricle is supposed to kick out 80 ml blood, and out of 80, if 10 ml will leak to the top, ultimately going out of the heart, that is left ventricle, will only be 70 ml. Now I want you to compare 70 with respect to 80. I mark my words. 70 ml blood as compared to 80 ml. 70 ml blood as compared to 80 ml will take relatively less time to go out. And if it is less time to go out, the aortic valve of the patient will not close on time, but will close relatively early. You can see, unlike valvular aortic stenosis, where I was saying that there was obstruction, so aortic valve will close late, here because the valve is having rather less transit of blood, because most of the blood is shunted from LV to LA, the aortic valve of the patient will close relatively early. And as a result of it, I can say the fact that if on a two-dimensional scale, if I represent it, this is the A2 part, this is the P2 part. In these patients, the aortic valve of the patient will close relatively early, so the gap between the two will be increased, and therefore the final output is that the patient will be having a wide split second heart sound. So wide split second heart sound is a feature that is encountered primarily because of early A2 that is occurring in patients of mitral regurgitation. And the same story will also be valid if I represent the shunting with respect to a VSD, which is the most common congenital heart disease in children. Even if you do not draw this, just follow the sequence of events here for VSD, which is the most common congenital heart disease, the acyanotic one, and overall the most common one also. When the left ventricle of the patient will contract, you see left ventricle has a higher pressure. Obviously, the blood is going to race into the aorta and the pulmonary artery of the patient, but you can see that the pressure difference will ensure the blood leaking from the left ventricle to the left ventricle to the right ventricle. If you compare the two diagrams, the only difference between the two diagrams is that one is having blood leaking from LV to LA, high pressure to low pressure. Now it is LV to RV, high pressure to low pressure. Shunting is same in both of them. So because shunting is same in both of them, because already some blood will go from left to right, you can see the blood that will exit into the aorta of VSD patient will also be lesser. I repeat again, the blood will be lesser because most of the it has already gone from LV to RV. So if less blood will go to the left ventricle, it will take less time to go out. Therefore, aortic valve will close early once again, and there would be early A2 contributing to development of a presence of wide split second heart sound. So mitral regurgitation and VSD, they both have a pansystolic murmur because there is a pressure difference between the chambers, and both of them would be having a presence of a wide split second heart sound. Now let us compare this with respect to ASD and see how the ASD splitting will basically shape up. First, if you look at the shunt diagram for ASD, you will notice the fact that this heart disease, which is common in children with Down syndrome, will be causing the following implications. This is the blood leaking from LV to LA to RA. This is the venous return. You can see that more blood is going into the right ventricle of the patient because most of the blood of LA is going into RA, and I have shown relatively less blood which is going into the left ventricle of the patient. So one, you can see that when it comes to a atrial septal defect in a patient, there is more blood which is present in the right ventricle. The more blood will take relatively more time for exit, and because the more blood will take more time for exit, the pulmonic valve of the patient will close relatively late. Let's do it again. The left side of the heart of the patient is containing less blood. Less blood to go out of the heart will take relatively less time, and therefore the aortic valve of the patient, because we're dealing with left side now, the aortic valve of the patient will close relatively early. So you can see the fact that in patients of ASD, I made you practice once again, more blood, more time, less blood, less time, and therefore you can see that one of them will close late, one of them will close early, and therefore once again the lines will be affected. And well, the same thing is happening in VSD also, but I just wanted to point it out once again in ASD also, that both are example of left to right sided shunt. So more blood in the left side, P2 gets delayed, and less blood on the left side, A2 gets early, and therefore the gap increases. So once again you can see wide split second heart sound is a feature of both VSD and ASD. Now comes the aspect of why do we say fixed split. So let's now look at why do we say a fixed split. So pay attention to the two shunt diagrams that I make before you. First, I'll just say physiology. And what I mean by physiology is that in you and me, during the phase of inspiration, relatively more blood comes in. You can see that in inspiration, more blood comes in. So I put I, inspiration, more blood comes in. And then I have said during the phase of expiration, relatively less blood comes in. So I have made two arrows of differential sizes to mainly highlight that in inspiration, relatively more blood is coming in and more blood will take more time to go out, whereas in expiration, relatively less blood is coming in, so less blood will take less time to go out. Which means the fact that in you and me, when it comes to A2, it is not affected by respiration, but the P2 part keeps on varying with respiration. You can see the fact that here there is more blood, so I'm just putting a big plus sign, versus relatively less blood with expiration. So the P2 of ours keeps on oscillating with respiration, and therefore this P2 part I'm showing now will move slightly to the right. I'm saying move slightly to the right in the phase of inspiration because more blood in inspiration will take more time to go out. Whereas it will move slightly towards the left hand side of this slide, that is during the phase of expiration, because less blood will take less time to go out and therefore it will go relatively early. So our P2 actually keeps on oscillating with inspiration and expiration, and the 30 millisecond time lag that I was talking about is actually between the A2 and the inspiratory position of P2, So the message learnt is that A2 does not get impacted by respiration, but P2 of ours keeps on varying with respiration. With respect to more blood, P2 gets slightly moved to right, less blood slightly moved to left. This is what happens in us. Now I'm going to superimpose ASD. Instead of doing it in the same diagram, which will make it a little untidy, I'm going to show this in a new diagram to you. So please follow and give me undivided attention on the board instead of taking notes at the moment. This patient is having a ASD, as you can see in the diagram. During inspiration, more blood is coming in the right side of the heart, and you can see that when I have shown more blood coming in the right side of the heart, the shunt is not operational. Why the shunt is not operational is because at the moment the more blood that comes in the right will cause equal pressure between the left and the right atria, and therefore shunt will not operate. So in inspiration, in ASD, the shunt does not operate in the phase of inspiration. However, in the phase of expiration, what's going to happen is that because of the fact that relatively less blood is going to come in here, so now the shunt will be able to operate in a sense that the blood will be able to come from left to right. So one, you can see that in ASD patients, the shunt operates only in one phase of respiration, that is expiration, and not in inspiration. Why not in inspiration? Because more blood will cause equilibration of pressures between the two chambers and the shunt will not operate. Now, whatever blood that will come from LA to RV will also traverse across the tricuspid valve and will go into the right side of the heart. If you take into consideration the amount of blood which is present in inspiration, it is obviously more, but in expiration you can see some blood coming by the shunt. If you calculate the amount of blood in the right ventricle of the patient in inspiration and in expiration, in these patients, we find equal amount of blood is present in the right ventricle in both inspiration and expiration. How that is possible? Inspiration understood, no more blood comes in, fine. In expiration, the shunt is also operational. So therefore, though we are having less blood coming in the physiological way, the shunt is causing more blood to come in the right ventricle of the patient, and we find that the amount of blood coming in the right ventricle is equal in inspiration expiration. Compare with you and me. In you and me, the amount of blood coming in inspiration expiration is not equal because we are not having any shunting. It's only physiological, right? But in this diagram, you can see the shunt operates in only one phase of respiration, that is expiration, and the amount of blood that is going to be coming in the right ventricle remains the same in both phases of respiration. So the splitting or the movement of the P2 will stop. The movement of the P2 is dependent on more and less blood. Now it's equal amount of blood, no? So movement of P2 will not occur. So therefore in these patients, first I will say wide split. The explanation of wide split I gave in the previous slide. Why I'm saying wide split? Because ASD causes overloading of the right and underloading of the left side. But in these patients, this diagram is mainly to explain to you that why is there a fixed split of the second heart sound in the patient. The word fixed split, I highlight once again, is because the amount of blood in the right ventricle during the both phases of respiration in the ASD patient is equal. Therefore, we call it a wide fixed split second heart sound. So the final output is wide fixed split second heart sound is a feature that is seen in patients of ASD. When it comes to murmur in patients of ASD, well, we don't have a shunt murmur. I've discussed that in the murmur section. You can read there. Reason why you don't have a shunt murmur in ASD is because the pressure difference between left atria and right atria is only about 4 millimeters of mercury. However, you are able to hear a flow murmur in patients of ASD, and that flow murmur that you hear is actually a mid-diastolic murmur. The investigational choice for diagnosing ASD is echocardiography, a transthoracic echo or a transesophageal echo, and that will be showing a gooseneck defect. And for treatment of these patients, we are gonna go in for a deployment of an occlusion device. This occlusion device will hold its position because the pressure difference between the LA and the RA is relatively very less. Therefore, on the basis of this explanation that I provided to you, I can now say the fact that the second heart sound can be having two inputs. One is called as narrow split second heart sound, and the second one is called as wide splitting of the second heart sound. When it comes to narrow split, I have already explained to you valvular aortic stenosis, the subvalvular aortic stenosis, and left ventricular failure in any of the methods discussed earlier. For the wide split, I can subdivide the discussion into variable split and a fixed split. When it comes to a variable split, it is VSD, V for victory, variable, V for VSD and mitral regurgitation. Whereas when it comes to fixed split, the fixed split is going to be a ASD, that is a atrial septal defect. Please remember the fact that when it comes to a ASD in a patient, that is a atrial septal defect, I had highlighted the fact that the shunt operates in only one phase of respiration, that is in the phase of expiration, and the amount of blood coming in the right ventricle is equal in both phases of respiration, which explains the P2 part not oscillating with respiration. In the exam, he can write ASD as not ASD, but rather as hold or arm syndrome. Hold or arm syndrome would imply that this would be presence of ASD with absent radius or skeletal defect. So he could just write the word skeletal defect or absent radius bone. Or instead of Holt or arm syndrome, he might write the word Lutem-Baker syndrome. Lutem-Baker syndrome is a combo of ASD with mitral stenosis. Or he might write conditions having ASD like Down syndrome, that is trisomy 21. Or you might write down a condition by the name of TAPVC, that is total anomalous pulmonary venous connection. But these are a couple of inputs or examiner's ways of which he will explain the word ASD. Once I've explained the concept of splitting of the second heart sound before you, I would like to add on to your knowledge now by adding a disease here. Let us assume this is the representation of bundle of hairs. The current always first goes to the left fascicle, then goes to the right fascicle. Why? Because the refractory period of the right fascicle is always higher than that of the left. The importance of knowing this: S1 is always written as M1 T1. It is not written as T1 M1. Why? Because the first current goes to left side and it causes mitral valve to close. Please appreciate that the closure of the mitral valve is not only dependent on pressure, but it is also dependent on this electronic circuit that I drawn before you, that current will first go to the left side, so mitral valve will close first. Similarly, when it comes to second heart sound, it is written as A2P2. It is not written as P2A2. Why is it written in physiology as A2P2? Because current will first go to left side. So first aortic valve will close, then pulmonic valve will close. So normal physiology, S1 is M1T1 and A2P2 because of this electrical circuit. Right fascicle has higher refractory period. So current takes a little more time to go to the right fascicle. Now we will incorporate an abnormality here. Let us assume a person is having a disease by the name of right bundle branch block. Current on the left side will flow just like normal, but on the right hand side, there will definitely be some wastage of time because the current will have to bypass this area, go via the myocytes, and then go into the Purkinje network subsequently. Therefore, I said there is wastage of time and there will be delayed information provided to the valves on the right hand side. What are the valves on the right hand side? Tricuspid valve and the pulmonic valve. So they will both get delayed information. Normally they get information to close on time. Now they're gonna get a delayed information. Let us look at the importance of this. I have written S1 once again before you by drawing these two lines M1 and T1. The left side information will go like normal in a case of right bundle branch block, but the right sided information will be delayed. So tricuspid valve will close relatively late and therefore the gap between the two will be increased. This would be called as wide split S1. Earlier I was teaching you wide split second heart sound. Now I'm teaching you wide split S1 is a feature seen in right bundle branch block. Let's practice this again for second heart sound also. First A2 closes, then pulmonic valve closes. In right bundle branch block patient, left-sided information will obviously flow on time. There's no problem on left side. Problem is on right side. The pulmonic valve will close relatively late. So again the gap is increased and I would like to call it a wide split second heart sound in the patient. Additional word that I would like to add here is wide variable split second heart sound. That variable word is coming mainly because of impact of respiration, because when we breathe in, more blood goes into the right hand side, more blood will take more time to go out. So variability is with respect to impact of respiration, that is with inspiration, expiration. In inspiration, more blood, so the P2 component becomes relatively more delayed with respiration. But the concept is wide variable split second heart sound is heard in patients of VSD. Remember, V for victory, VSD has a wide variable split. Additional point to be remembered is right bundle branch block will also be having a wide variable split second heart sound. Now we will use English and put opposite words of this. Like let me say person is having left bundle branch block. Then patient will be having narrow split S1 and narrow split S2. One way to remember is if you remember the information for right bundle branch block, just use English. Right opposite is left. Similarly, wide opposite is narrow. So you can work out the information. However, because I want you to practice it at least once, so let's just do it here. This diagram is now going to represent a patient having damage to the left fascicle, let me say after myocardial infarction. Therefore, in left bundle branch block, there would be wastage of time here. There would be delayed information provided to the left-sided valves. First heart sound is written as M1 T1. In this patient, there will be a delayed information provided to M1. So mitral valve will close relatively later in the patient. So I'm shifting this dotted line slightly to right to say that mitral valve is closing late and therefore the gap between the two lines is becoming lesser. Patients of left bundle branch block can die because of pulmonary edema. In the casualty, when you auscultate them, they will always be having a narrow split first heart sound. In fact, it's a possibility that this narrowing can be so serious that mitral and tricuspid might start closing at the same time. So don't be surprised if he says the word single S1 in patients of left bundle branch block. Why? Because the mitral valve is closing later and both might be superimposing and therefore single S1 might be written. Let us practice for S2. S2 is aortic and pulmonic valve closure. There's a 30 millisecond time lag between the two. Because of the delayed information provided to the left side valve, the aortic valve will close late. So the gap between the two, because A2 will now get shifted to right. So again, the gap will become less. This will result in generation of a narrow split second heart sound in a patient. So we have just added to your vocabulary. Like earlier, I was teaching you narrow split second heart sound is a feature of left ventricle failure. I gave example of patent ductus arteriosus or aortic stenosis, hypertrophic cardiomyopathy. Additional information to be remembered is left bundle branch block will also be having a narrow split second heart sound. Out of the informations provided in the two slides, the carry home messages for you are at least two. Narrow split second heart sound is also found in patients of left bundle branch block. The opposite of this, wide variable split second heart sound, is found in VSD. Wide variable split second heart sound can be found even in patients of right bundle branch block. Now to see whether you got me or not, I'll make you practice once again, but in a slightly different fashion. I'm going to describe a person having Wolff-Parkinson-White syndrome. This is SA node, AV node, then is going to be the bundle of phase here. then is Purkinje. It's gonna be innervating the myocardium. And now I am gonna show a patient having bundle of Kent. This bundle of Kent has no decremental properties. It conducts very fast. Unlike AV node, which is very slowly conducting, because AV node has AV nodal delay, it's innervated by vagus nerve. There's a slow conduction by the AV node. The bundle of Kent does not have decremental property. The impulses will race straight away from the SA node via this bypass pathway directly into the left side of the heart. You can see, let me say this is the left and this is the right. So hypothetically speaking, I can just put numbers here by saying that the way I have drawn the diagram before you, the current will be entering on the left ventricle side first and then will be going in the right ventricle. Normally, the current always goes first into the left and then goes to the right. That is okay. But in this case, it is going the abnormal way and is first activating the left ventricle, then activating the right ventricle. Therefore, because the current in this case will not be utilizing the Purkinje network, but will be using intermyocyte conduction, the right side impulses will be always delayed. I repeat my statement. Why is there a delay of the activation of the right ventricle in this particular diagram? Because the current is not going to utilize the Purkinje network. It was never going by the AV node. For us, Purkinje network is used. Current goes from SA node, AV node, bundle of is Purkinje. Here Purkinje is not getting used. It is intermyocyte conduction which is getting used here, and therefore what is happening is that there is a delayed information provided to the right ventricle. Therefore, this description that I've given you is called as Wolff-Parkinson-White syndrome type A. Meaning of the word WPW type A is that this bundle of Kent is left-sided. That's itself a question for you. WPW type A is left-sided bundle of Kent. If I draw this bundle of Kent on the right-hand side contralateral, it will become WPW type B. Now, the concept that I want you to understand is Wolff-Parkinson-White syndrome type A, where the current is going first to the left and then to the right. There is a delayed information which is provided to the right ventricle. Therefore, it will behave like a right bundle branch block. Let me show you the diagram of right bundle branch block. In right bundle branch block also I was saying the same thing, no? Right side there is a delayed information provided. The same concept has been shown right now in WPW type A, that is right bundle branch block will occur in this patient, or manifestations of right bundle branch block will occur in this person. Why? Because the left ventricle will be activated first and then the right ventricle. Therefore, even this condition will be having a wide variable split second heart sound. This is the additional information that I've added. Wide variable split second heart sound was taught to you for right bundle branch block. Now I've added the same information for WPW type A. Let's practice this one last time so that this becomes a permanent memory for us. This is normal conduction system once again being represented before you. This is Purkinje. It innervates the ventricular myocardium, and now I have shown WPW type B. The fascicle that is present, the bundle of Kent that is present in this patient is right-sided. Therefore, the current will now be first activating the right ventricle of the patient. I'm putting 1 to say first right ventricle will be activated, and then the current will travel not via the Purkinje but via the intermyocyte conduction and will go and activate the left ventricle. Therefore, WPW type B has a delayed information provided to the left ventricle, so it behaves like left bundle branch block. And what is the auscultatory finding of left bundle branch block that I taught you? Narrow split second heart sound in a patient. So let us just summarize the information that has just been taught to you for the two additional aspects related to splitting. I have added the fact that if they ask you about narrow split second heart sound, the first example that I want you to remember for narrow split second heart sound is valvular aortic stenosis / hypertrophic obstructive cardiomyopathy. Then are causes of left ventricular failure like anterior wall MI or beriberi or severe anemia in a patient. The pediatric example that I gave you was patent ductus arteriosus. To this background knowledge of yours, I've added additional points, which is that narrow split second heart sound is also found in left bundle branch block and is also found in Wolff-Parkinson-White syndrome type B. What do I mean by type B? Reminding you once again, the fascicle is right-sided. So current will go first in the right fascicle and delayed information to the left side. So it will behave like left bundle branch block. So both of these are indirectly meaning the same. So these are examples of narrow split second heart sound in a person. If you just apply English, you can apply the opposite data for wide split second heart sound in a person also. So if you try to get this information right and you practice it, you will be able to score relatively better. One last effort at this wide split second heart sound. It is subdivided into variable split as well as a fixed split. For the variable split, I want you to remember VSD, mitral regurgitation, and a right bundle branch block. Wide fixed split is a feature of atrial septal defect. ASD can be written as Holt-Oram syndrome, or it could be written as total anomalous pulmonary venous connection, or it could be written as Luton-Baker syndrome, which is a combination of ASD with mitral stenosis. Those are the traditional pediatric terminologies that he can be using before you. But if you get this practice right, you would be bang on spot to identify questions for narrow split versus wide split. So do practice the last two tables that I made before you for narrow and wide, and I am very sure that your performance will increase. Thank you so much for your patience, for hearing me out.